the latest results of the gene therapy clinical trials in both hemophilia A and B. And these are my disclosures. And before I go over the clinical trials, just a couple of backgrounds. In fact, I think just one background slide to give you an idea of gene therapy. I know you've all this has been top of mind for many of you for a long time now, but just to review what we're talking about when we talk about the gene insertion therapy for hemophilia A and B. The first problem is to create the vector. The vector is the delivery vehicle that delivers what we call the transgene. That is the gene for factor VIII and factor IX, in this case to the liver. And this is, in order to do this, we need a delivery vehicle. And the vehicle that's used is a virus, because viruses have figured out how to get into cells for eons, and we haven't figured a better way to do it yet, although people are working on it. So we use a natural virus called AAV, and that's shown here. It stands for adeno-associated virus. It's got only two genes, rep for replication and cap for capsid. These two genes are removed, and instead what's inserted there is GOI stands for gene of interest. In this case, the genes of interest are either factor VIII or factor IX. So we use this capsid to deliver the gene of interest to the cell. And what that looks like is shown here on the right-hand part of the slide. So this is the vector containing the gene of interest. It goes to the cell, in this case, a liver cell called a hepatocyte. It's internalized into the cell. And if you follow the pathway on the right-hand side here, it delivers its payload, which is the gene, into the nucleus of the cell. That's the white part here in the bottom right. And the payload, the gene, largely remains outside the DNA of the cell itself. So the DNA that we deliver, the factor VIII or IX DNA, remains as a little circular body called an episome within the nucleus. So that's where the site of action. But what is shown here on the left is important too. This shows what happens to the delivery vehicle itself, the capsid. And the capsid consists of proteins which are broken down and which can then incite an immune response by being presented on the surface of the cell. And that's important in terms of our ability to perform gene therapy, because if you mount an immune response against the capsid, you're not going to be able to be a candidate for gene therapy. So that's all I'm going to talk about, the background of gene therapy. And what I want to talk about now in the remaining 20 minutes or so, or 25 minutes, is the results of the gene therapy clinical trials. And the first AAV vector gene therapy clinical trial that was reported and that was successful was reported back in 2011. And this used this adeno-associated, or AAV vector, and it used natural factor IX, which we sometimes call wild type factor IX. That's an unmodified form of factor IX. And this gave low levels of factor IX, and the patients who were treated and reported back in 2011, they're still making factor IX. So it worked. This was a proof of concept. Now, the first factor VIII gene therapy that was successful using AAV vectors wasn't reported until 2022. And I apologize, the names for these transgenic vectors are very complicated, so I won't try to pronounce it. You don't have to know this, but this is the first successful hemophilia A gene therapy, so delivering factor VIII rather than factor IX. And this was also the first hemophilia gene therapy to be approved anywhere in the world for clinical use, approved in the United States and in Europe, not yet approved in Canada, but it is under consideration. So what I'm going to do is now show you the results, or the high-level results of this clinical trial. So this is the factor VIII, which is we hope to have available in Canada for clinical use, but has been made available for the last couple of years in other parts of the world. So first of all, if we look at the results, we should look at the amount of factor VIII that the patients who were treated with this express. And if you look on the left-hand side of the slide here, this is the whole population, 132 patients. So it's a big study. And this is up here, what I'm showing is the number of vector particles that were injected. And this is a very big number, 6 × 10⁻13 genome copies per kilogram. So that means a 100-kilogram man would receive 6 × 10⁻15. Now that's a very big number, 6 with 15 zeros after it. to give you an idea of what that means, that's more than the number of cells in the human body. And that's what we inject to perform gene therapy for hemophilia. And the factor VIII that's used is not natural factor VIII. It's a B domain deleted. That's a truncated form of factor VIII. But the reality is most of you who are on recombinant factor VIII gene therapy, you're getting B domain deleted factor VIII. So this looks very much like a drug like Xintha. So the results, if you're shown, are shown here on this slide. 132 patients up to 52 weeks. And let me point out a few things for you to pay attention to. The diamonds show the mean or average level of factor VIII over the first year. And you can see they get very good levels up into the mild hemophilia or normal range. So that's one thing to look at. The other thing to look at are these error bars, these bars, and you can see that they're huge, showing that there's a tremendous amount of variability down to 0 in some patients, no expression at all. And in some study subjects, expression above the normal value. So a tremendous variability. The other point that I want to show you is that these levels peak within the first few months and then start to slightly decline. And when they looked at the subset of patients who were followed up to 2 years, 104 weeks, but this was only 17 subjects now, so much smaller number, you can see the same thing. The rise to a peak level within the first half year or so, and then a slow decline. And that is something that is seen in the factor VIII hemophilia gene therapy studies. Now, the mean levels are still in the 20s. They're still very good, very therapeutic. These study subjects still have mild hemophilia for the most part, most of them, some of them in the normal range, some not expressing. So that's the factor VIII levels. Now, what does that mean in terms of clinical response, though? So what's the, I mean, you know, we look at factor VIII levels, but the most important thing is what's the bleeding like? And that's shown here. And this is again from the same paper published last year. And what this shows here, if you look in the left-hand side of this pie chart, this tan color, you can see that close to 50%, 49% of patients did not bleed either before or after gene therapy. Now, they didn't bleed before gene therapy because they were on prophylaxis. They were either on emicizumab or on factor VIII prophylaxis. So they're severe hemophilia patients. They all had severe hemophilia, less than 1% factor VIII. They didn't bleed before gene therapy, and they didn't bleed after gene therapy. This blue segment of the pie, 26%, are patients who, I'm sorry, actually, I said that wrong. Let me retract that. These are patients who did bleed before. They did have some bleeding in the year before gene therapy, but no bleeding after. These 26% are the ones who didn't bleed either before or after gene therapy. So you put these two together, the tan and the blue, that's 3/4 of the patients. 3/4 of them did not bleed in this follow-up period after gene therapy. 3/4 didn't bleed at all. This slice of the pie, about 15%, did bleed both before and after gene therapy, but their bleeding rate declined after gene therapy. So they did get some benefit, but they didn't have complete cessation of bleeding. And this smaller slice of the pie, 9.7%, bled both before and after therapy and actually did have increased bleeding after gene therapy. So again, as I showed you in the previous slide, highly variable factor VIII levels. Some patients did bleed, and in fact, 12 or 13% of the patients did go back to prophylaxis with either emicizumab or factor VIII. Now, another way of looking at the data then is how much factor VIII did they use? So if you look here at the blue or gray bar, this shows the annualized rate of factor VIII use. So this is total units, international units of factor VIII used in the year before, or the annualized in the average year before gene therapy. And this is units per kilogram. So about 4,000 units per kilogram in the year before, or in the years before gene therapy. And after gene therapy, annualized rate, 56,000. That's a reduction of almost 99% factor VIII use. and the number of infusions, the number of shots of factor VIII they had to take in the years before on average. So this is not emicizumab patients. These are patients who are on factor VIII concentrate. 136 shots a year of factor VIII before gene therapy. After gene therapy, two infusions a year of factor VIII. That's, again, a reduction of about 99%. So very, very positive and very impressive results. And this is what led to the approval of this product in the US and the EU, and it's being considered, as I said, in Canada. Now, there's another factor VIII gene therapy that's not yet approved, but it is in late phase clinical trials. And I'm just going to show you one slide about this other product for factor VIII. So it's another AAV-mediated, vector-mediated factor VIII hemophilia A gene therapy clinical trial. And I'm showing you this for one reason that I'll show you in a moment. This is very small numbers. This is only 4 or 5 patients. You can see along the bottom here the number of patients, but I'm showing it to you to make a point. First of all, the same pattern that we saw in the other one. If you look at the diamonds rising to a peak within the first half year and then slowly declining up to 130 weeks. But the real reason I'm showing you this is to show you what I've highlighted here with the red line. This is factor VIII measured in 2 different ways, by a chromogenic assay and by a one-stage clotting assay. This is, some of you may know what I mean by this. There's 2 different ways that we can measure factor VIII, which we do measure in our laboratories and the hemophilia treatment centers. And there are some products will react differently to the different assays, which is why we use them widely. But look at the difference in the results using these 2 assays. This is the same data. It's just the exact same samples assayed using 2 different methods, and look at the difference. This red line, which is kind of the mean peak level, is at about 75% factor VIII using the chromogenic assay, and using the one-stage assay, the mean peak level is about 125% factor VIII. So these are the exact same samples measured 2 different ways, 75%, 125%. Which one is more real? Which one is true? It's embarrassing to say this, but the truth is we don't know. So we don't even really know how to measure factor VIII or factor IX, which is the most biologically relevant way to measure it. And we see the same differences that I'm showing you here for this factor VIII study. We see the same differences in the factor IX study. When we measure them by the standard, the most common one-stage clotting assay, we get systematically, we see higher values than we get with the chromogenic assay. You know, that's kind of, as I said, embarrassing, but at least what we do know is that most of these patients don't bleed. As I showed you, the bleeding rates dramatically reduced, the factor VIII usage dramatically reduced. So let's turn now to hemophilia B, so factor IX gene therapy. And this was the first approved hemophilia B gene therapy. This is approved in Canada and elsewhere. And this was published last year, this study. And this is the drug which some of you may have heard of, called Hemgenix. And again, if you look at the diamonds are the mean or the average factor IX levels. This goes up to 18 months. And you can see levels in the, first of all, you'll notice, again, the very wide error bars, some patients up in the normal range, some down very low. But the average or mean levels are up in the 20s, 30s, 40% range. And you can see that this is more stable than the values I showed you in the factor VIII clinical trials. And this is something that we are seeing with factor IX for a variety of reasons that we hypothesize, which I won't go into now, but it seems that factor IX gene therapy does give more stable levels than factor VIII. Now, if you look at the clinical correlations on the right-hand side of the slide, the number of factor IX infusions, the number of shots per year before gene therapy, these are means, 72 shots a year, after 2.5 shots a year, 97% reduction. How many units per year of factor IX? 257,000 units before, 8,000 or 8,500 after, an 88% reduction. ABR means annualized bleeding rates. So the average number of bleeds per year for, this is on prophylaxis, but 4 bleeds before gene therapy, 1.5 bleeds after gene therapy, a 64% reduction. So using very little factor IX and yet bleeding considerably less. So that's the first factor IX gene therapy that's been approved. There's another one. Sorry, this is a 2-year update on the same product. So this is the Hemgenix product again, a 2-year update up to 24 months. And I just show you this to show that those factor IX levels are remaining stable. So up to 24 months, we don't see that drop off that we see with the factor VIII gene therapy. And if you look on the right-hand side of the slide, what this is showing is the severity of hemophilia that they're left with after the gene therapy. And I've simplified it here. I've just taken their data and made it a little bit simpler to look at. So 57% of the subjects in this trial, and we're talking about 50 patients, 57% are in the mild hemophilia range. Mild hemophilia defined as 5 to 40%, or 0.05 to 0.4 international units per milliliter. That's a standard consensus definition of severity of mild hemophilia. A third of them, 33%, are in the normal range. So put these together, you've got 90% of patients are either normal or mild, mildly affected. 6% are left with severe hemophilia. So again, unpredictable. Not everyone responds. Fortunately, only 6% either were left with severe hemophilia by the numbers. That means less than 1% or less than 0.01 IU per mil factor IX. And the gray slice of the pie is just a few subjects for whom there was not data available. So that's the first licensed factor IX hemophilia B gene therapy. And there's another one. This is the second one. This is the other product that's licensed here in Canada. And you may have heard of this. This is called Becvez. And this product is shown here. By the way, one thing I didn't make a point of showing you earlier is that the number of vector particles injected in these factor IX clinical trials is considerably less than in the factor VIII clinical trials. Those were in the 10 to 13 genome copies per kilogram range, and these are in the 10 to 11 genome copies per kilogram. So that's 100 times fewer particles. Still a huge number, but 100 times less than the particles that are needed to get good levels of factor VIII. So these are the hemophilia B trials. So again, the plus signs here are the mean or average factor IX levels, and you can see they're getting into the 20s and 30s, and again, stable up to 24 months. And the clinical correlation with these levels is shown here. The mean or average annualized bleeding rate dropped from 4.4. And remember, this is on prophylaxis with factor IX. And after treatment, 1.3, so a 71% drop in the annualized bleeding rate. Even though they were on a very good prophylaxis before treatment, they still bleed less after gene therapy without factor IX prophylaxis. But again, similar to the factor VIII trial that I showed you earlier, about 13% did return to factor IX prophylaxis. In other words, they didn't have a good enough response to the gene therapy to rely on it. And a 5-year follow-up, and now we've got very small numbers, 15 here in year 1, 7 in year 5, but this is just to show you that the levels remain reasonably stable in the 20% range with annualized bleeding rates under 1 in all these patients between 0 and 0.9. That was the annualized bleeding rate in all of these patients. And no additional patients have resumed factor IX concentrate prophylaxis. So to summarize the clinical trial results, factor IX expression levels have reached the mild hemophilia or the normal range in most patients and seem to be stable for many years, whereas factor VIII expression similarly reaches levels that are variable in the mild to normal range in some cases even abnormally high, but a slow progressive fall is seen after the first year. And the mathematical estimate for the rate of fall of that factor VIII, so we can call it a half-life by analogy to the half-life of a factor VIII infusion, is estimated to be a little over 2 years, 123 weeks. And so on average, again, the mathematical predictions suggest that the average patient may get up to 5 or 7 years of effective prophylaxis out of this gene therapy for factor VIII, although some will get considerably more, we anticipate, and some less. The bleeding rates and factor concentrate usage for both factor VIII and factor IX gene therapy clinical trials are drastically reduced. And I didn't go over adverse effects, but there are very few serious adverse effects from gene therapy infusion. The treatment is generally well tolerated. A few patients do have infusion reactions when they actually get the dose of gene therapy, of the vector, but that has not prevented anyone from getting the full dose. And most patients don't have any infusion reactions at all. So I've got 2 more slides to show you. This is just to review briefly the risks and the challenges that we still have with this generation of gene therapy. And I call this the first generation of gene therapy because there will be other generations. First of all, what we call neutralizing antibodies to AAV. AAV is a natural virus. It's the adeno-associated virus. We're exposed to it in the environment. And up to 40 or 50%, varies with different populations, may already have antibodies. In other words, if we have had an asymptomatic infection with this virus, we may have an antibody to it. And most of the clinical trials exclude anyone who has those antibodies from treatment with the expectation that they won't respond very well. And even if you don't have antibodies against that virus, and you don't have antibodies that will interfere with the vector infusion, you are going to develop them after the gene therapy. Remember, when you inject 10 to the 11 to 10 to the 13 particles derived from this virus into your bloodstream, you are going to develop an antibody against the capsid, and you won't be able to have AAV gene therapy again if you need it. However, we hope that we'll be able to offer you other treatments, including other gene therapy products. Another point is steroids. These are corticosteroid treatments are needed in some patients, more in the factor VIII than in the factor IX gene therapy trials. And this is because some patients do develop a mild form of hepatitis after gene therapy. Now, that hepatitis is not very damaging to the liver. It's actually quite mild. The liver recovers just fine. We're not worried about the liver being damaged. We are worried, though, that sometimes that form of hepatitis is associated with a loss of expression of the factor VIII or factor IX. And because sometimes we think that's an immune response to the capsid, the vector particle, to try to rescue the factor VIII or factor IX expression, we do give short courses of steroids. Now, the reason I make this point is because steroids can be uncomfortable. There can be unpleasant side effects from these steroids. They're generally reversible, but we can't guarantee that any individual who gets gene therapy that we won't recommend it for him, and it can cause unpleasant side effects. These gene therapy protocols are all unsuitable for children. And the reason is that I showed you on the very first slide that most of the vector does not integrate into, or most of the transgene that's delivered by the vector does not integrate into the patient's or the individual's genetic material, meaning that as the cells divide, it will be diluted out. Now, children grow and their livers grow. And so as a child grows, we would expect the gene therapy effect to be diluted out. That's not the case in adults. Our liver cells divide very, very slowly. They're essentially what we call post-mitotic. They almost don't divide at all. So That's why all the clinical trials have been done in adolescents and adults. So children are excluded from these trials. As I've made the point several times already, the degree of response and the duration of effectiveness are unpredictable in any individual. There is a theoretical risk of cancer, especially hepatocellular carcinoma, that is cancer of the liver. And the reason is that although these the AAV-derived vectors are largely non-integrating, there is no such thing as non-integration. There is some degree of integration, and that ends up really being millions and millions of liver cells do have integration. And if that gene is integrated, the factor 8 or 9 gene is integrated into a part of the DNA that stimulates production of liver cancer, then it could theoretically induce a liver cancer. Now, this is a theoretical concern in that it has not been seen in any of the clinical trials, has not been seen in any of the animal models. Now, a little asterisk, there was one patient in one clinical trial who did develop a hepatocellular carcinoma, a liver cancer, but detailed molecular studies of that cancer really showed quite conclusively that the gene therapy was not the cause of that cancer. And then there's another theoretical harm. Since, as I showed you, some patients actually achieve levels of factor 8 or 9 that are excessively high, that are higher than normal. Now, we don't think that's very harmful. Some of us have levels that are higher than normal, even at baseline, but it is at least a theoretical concern. And my last slide is shown here, future directions in hemophilia gene therapy, just to give you an idea of what might be on the horizon. One of the approaches is going to be using viral vectors that are deliberately integrating. So they deliberately integrate into what we call a safe harbor or a safe spot within the genome so that they're predicted to have more stable long-term effects and they'll be suitable for children. Another approach to this, which is being used now, starting to be studied with still with AAV vectors, is using gene editing techniques, using the CRISPR-Cas9 protease system, which allows the delivery of the AAV vector payload, the factor 8 or 9 gene, to a predetermined spot within the individual's genome where it's not going to cause harm, where it's not going to cause liver cancer, but where it will still express safely. So a lot of good things to come in the subsequent generations of gene therapies.
Thank you very much, Dr. Teitel. We appreciate your time and your contribution to our education. We have a couple questions, and I'm going to just begin with one question that we had received ahead of time. As far as you're aware, what resources are there for psychosocial support for the patient receiving gene therapy?
Well, I think that's an important consideration, Sarah, both before and after. So there's a lot of considerations for someone who might be contemplating gene therapy. And then there are considerations after gene therapy, even whether it works well or doesn't work well. So it is an important question. And I think we turn to the hemophilia treatment centers. So, our hemophilia treatment centers are multidisciplinary and they're comprehensive. And comprehensive management and comprehensive healthcare includes psychosocial support. And if we can't be delivering that, that's our job. If we can't deliver that, then we shouldn't be contemplating delivering gene therapy. We shouldn't be delivering any therapy for hemophilia unless we can offer those psychosocial support. So I don't know, maybe I'm avoiding the question, but what I'm saying is that the hemophilia world is, I think, well organized, we're collaborative, and I am confident that we'll be able to offer the appropriate support we need. This is exciting stuff. It's not going to be for everyone. It's certainly not in the first generation, but it's exciting. We've been waiting a long time, and I think we'll be able to support our patients through the journey.
Thank you. A question that we had from the audience, with the error bar in factor assay being so large and uncertainty value being big, are the data still statistically significant?
Absolutely. You saw the reduction. factor VIII levels and factor IX levels, that's one output. It's obviously an outcome, but what's the most important outcome? The most important outcome is, do you bleed? I mean, hemophilia is a bleeding disorder. So do these people bleed after gene therapy? You saw the degrees of reduction of annualized bleeding rates, factor VIII usage and factor IX usage, number of infusions after gene therapy. They fell not to nothing, but they fell by, between 65 and 90%. Those are highly statistically significant. They're highly clinically significant. They're highly important. So yes, it works. And, if it didn't, then we wouldn't see these products being approved in Canada, the US, the EU, around the world, and they are approved. So it's a big problem that it's unpredictable. We give you factor VIII, or we give you emicizumab, we give you factor IX. Unless you've got an inhibitor, we can tell you exactly how you're going to respond. There's still some error. Some people respond better, but we know what you're going to get. We give you gene therapy. We have to admit it is a bit of a gamble. We can't avoid that. It's an important problem, an important limitation.
Okay, thank you. Another question from the audience, and it's a multi-pronged question. I'll read it in its entirety and then we can break it down. How often is steroid treatment required for patients? Are those regimens high dose? Is there any evidence of thrombotic events in the patients who experience excessively high levels?
Okay. First of all, in the factor VIII clinical trials, the majority, more than half of patients need steroids. In fact, some of the trials, some of us aren't too happy with this, but some of the trials use steroids or other immunosuppressive drugs up front, preventively, prophylactically. But the majority of patients in the factor VIII clinical trials will need a course of steroids. In factor IX trials, it's less than half. It's a minority. It's probably less than 30% requires steroids. The courses are, we model them after the way we treat other diseases with steroids, other immune diseases, which are, yes, high dose courses, but brief. So I think our goal now, I have to tell you that we're not exactly sure the right way to use steroids. We're not even sure if steroids help everybody. So there's a lot of uncertainty here, but we use brief high dose courses and try to taper them quickly. And after the first 3 to 6 months, there should be no need for steroids at all. So this is something that's upfront, it's front loaded. If you need it, it's going to be short term. You may or may not. Some people sail through it and have no side effects at all. Others just hate steroids. We've been using them since the 1950s in various diseases. So, we're very comfortable as hematologists. We use these, it's part of our regular treatment, but they can be unpleasant, especially in this population who's never had to use them before. It's never been part of hemophilia care other than maybe intra-articular steroids injected into joints, but systemic steroids we really haven't used. So we have to warn people about this. It's something new.
And
I'm sorry, thrombotic. No, thrombotic. It's an interesting question. One of the clinical trials was actually interrupted briefly, put on hold, because there was a lot of patients who had levels of factor VIII that were very high. No one has had any thrombotic events. And some of us have factor VIII levels at baseline that are over 200, 300%. And it's a very, very minor risk factor for thrombosis. So I don't want to emphasize that. I think that's a very minor consideration.
And one last question before we go on to our next speaker. What are you most optimistic about in light of hemophilia B gene therapy now becoming a reality in Canada?
Yeah, I think particularly for hemophilia B, the results are excellent. The adverse effects are very few. I think the other point, however, of course, is that we've got excellent long-acting factor IX concentrates. Some people use it every 10 to 14 days. And we've got other subcutaneous treatments for hemophilia B that are coming in the pipeline that, are not yet available. But hemophilia, or gene therapy rather, I think absolutely has a place. This is the only treatment that we've got available that can give us the promise of long-term control. Whether or not it's forever, we can't say that. That would be perhaps a bit of an exaggeration. In some people, it will be. But long-term control, we can't promise that with any other therapy we've got. So it's a completely different ballgame.
Well, thank you very much, Dr. Teitel. We greatly appreciate your participation tonight. And with that, I'm going to now introduce David Page. David is with the CHS Blood Safety and Supply as a blood safety and supply consultant with the CHS. Among many other tasks, he has since 1994 worked closely with members of the Blood Safety and Supply Committee to rigorously monitor the latest scientific publications and communicate important issues with the bleeding disorders community. His diligent work in relation to products in development is more than essential to our understanding of the advancements of gene therapy. So without further ado, David, I will turn this over to you.
Thanks very much, Sarah. I thought we were going to have the Beatles sing A Long and Winding Road, but turned out that the royalties were too expensive. And then I was hoping, Sarah, you would sing, but that didn't happen either. So we'll just have to move on. I'm really happy to be here with you on International World Hemophilia Day to talk about not the science of it, which Jerry did, but you know, how are we going to get access for this in Canada? And I need to advance. It won't advance. There we go. So first of all, my disclaimers, I'm not a physician and I make no recommendations on treatments, and I'm not a health economist. And so the opinions expressed here and the analysis presented are really my own, and I take full responsibility for it. Jerry talked a bit about the history of gene therapy, the cloning of the genes way back in the 80s, you know, the first recombinants in the 90s, the beginning of gene therapy clinical trials in other diseases in the early 2000s, and then the first hemophilia clinical trials at the beginning of the last decade, and then, as Jerry described, the first approved therapies in hemophilia A 2 years ago, and last year in hemophilia B in Europe and then in the US. I think we need to understand whether or not we'll ever have access to these therapies. We need to understand who makes the decisions. And it's complicated. Health Canada is our regulator for the entire country, including Quebec, and they approve new drugs. They decide whether or not they're safe and efficacious. The next stage is the health technology assessment stage. ENES does that in Quebec, CADIF for the rest of Canada, and they make recommendations as to whether drugs are cost effective, especially in comparison to current therapies, emicizumab, factor VIII for hemophilia A, and factor IX for hemophilia B. If those recommendations are positive, it moves on to the next step. And the next step in this case is the Pan-Canadian Pharmaceutical Alliance. This is an independent, not-for-profit organization whose members are the provincial, territorial, and federal governments. And their job is to negotiate drug prices on behalf of the federal, provincial, and territorial public drug plans. So if all goes well, drugs are approved, recommendations are positive from a cost-effectiveness point of view, and a price is negotiated, then it comes down to the provincial and territorial ministries of health who are responsible for healthcare delivery, and they decide whether or not to add a new drug to the drug formulary for reimbursement through the public healthcare system. And then the last stage, of course, is what we all know much better, deciding whether or not to take a drug. Physicians need to decide whether they can prescribe the drug, and patients need to decide whether or not they're interested in receiving it. And that is really together makes the shared decision-making process. I have to say here that this may be all new to many of you, because unlike other coagulation products, with gene therapy, neither Canadian Blood Services nor Hemo-Quebec is involved in the procurement or delivery or price negotiation. So it's different from all the drugs we've had approved before, factor products, emicizumab, which went through Canadian Blood Services or Hemo-Quebec. So back to our long and winding road. Hemgenix was approved in October last year. Becvez by Health Canada for hemophilia B in December. And then just very recently, Becvez received a positive recommendation from CADTH with conditions, and Hemgenix received also a positive recommendation with conditions. And we'll come back to the conditions in a minute. INES has not released their recommendations yet for Quebec. They're expected any week now, and they could be different. In the past, we've seen CADTH make one recommendation and INES make a different one. So we're quite curious to see what INES will say. So I mentioned those conditions. What are those reimbursement conditions? Well, there are certain medical conditions which really make perfect sense. As Jerry said, these therapies are for adults only at the moment. They have to have no history of inhibitors. No research has been done with inhibitor patients. And there are the AAV antibody considerations. Testing must be done, and people who are over a certain threshold of the AAV antibody are not eligible for the therapy. CADTH has said they should be prescribed by hemophilia specialists, which makes perfect sense. And they've said there should be a price reduction from the current list price of $4.7 million for one-time treatment. And there needs to be consideration of the budget impact. And could there be alternative reimbursement models which may reduce the annual budget impact? So again, back to the road. The price negotiations with the Pan-Canadian Pharmaceutical Alliance have started, so that's good news. They typically take 6 months, so we could be into the fall of this year or winter of next year before those prices are finalized. And then once you have the ministries have a price to look at, they have to start to consider the recommendations they've received, the pricing, the budget impact, and make a decision as to access. Unlike emicizumab, where there was a single decision for Quebec and one for the rest of Canada, 2 decisions, here it's possible that decisions will be made province by province. You could have one province saying yes and another province saying no, and that could be complicated. Please don't ask me an access date. With all these different timelines, it's really impossible to predict. But I have to say that things have been moving along quite quickly in the last year with the Health Canada approval, the positive recommendation from CADTH, and negotiations already underway. So it's actually happening more quickly than I expected, but does that mean we'll have access more quickly? I don't know. Now, you may have jumped out of your seats at the $4.7 million price tag. I don't blame you. And you might have said, well, that can't be cost effective. No government will approve a payment such as that. I'm going to make an argument that, yes, it could be cost effective. And I'll use the example of hemophilia B because that's the one we have in front of us right now. So the current cost of treatment products for an adult on EHL factor 9 prophylaxis is around $200,000 per year by my estimate. We could get a negotiated price for gene therapy at maybe 1.8 million. It could be less, could be more, I'm guessing. But I'm proposing that that payment could be amortized over 6 years at $300,000 per year, something like a mortgage on a house. Let's say 15 patients are treated in each of years 1, 2, 3, and 4. So 60 patients overall out of the 140 who have adults who have severe hemophilia B. We've heard that the efficacy is likely to last 10 years or more, and no prophylaxis will be needed for at least 90% of those people. We could also have some conditions where there's pay for performance. So if in a certain patient the gene therapy is unsuccessful, there'd be no payment. Or if the efficacy fades over years 2, 3, 4, 5, payments would stop or be reduced. Now, this is just talking about the drug costs. This model does not take into account any of the other savings to the health system. So fewer appointments, fewer hospital visits, fewer surgeries down the road because of better prevention of bleeds. And it doesn't take into account the savings to individuals and families, higher productivity, less time lost from work, etc. How does that work out in terms of numbers? Well, this is a bit complicated. In the blue here, these are the savings in factor 9 per year. And here you see the number of patients increasing and then staying at 60. And all these are the savings in terms of factor 9. In green, we have the cost of hemophilia gene therapy if it's amortized over 6 years, 15 patients a year until we get to 60. And then they're paid over 6 years, and then the costs fall off. Here you have the annual budget impact. It's negative, it's in the red for the first 7 years. But by year 8, we're back into the black. So the annual budget impact is positive for governments. And here you have the total budget impact. And that's negative for many years, but it then turns positive in year 10 or 11. In other words, governments are providing perhaps a superior therapy for patients, and in the end, in the long term, it will cost less. Now, governments don't have a great reputation for looking long term, but if they do, these are the likely results. I'm not the only one to say this. Some of the American health technology assessment groups have come to the same conclusion about gene therapy in the States. So my point is, yes, it's expensive, but you've seen the benefits that Jerry described, and I think it could be cost effective in the long run. I invite you to read more about gene therapy. We have an excellent booklet which describes some of the things that Jerry talked about. We have a series of 10 podcasts with international experts from around the world. Jerry Teitel is one of those experts. And then this is the first of our webcasts, and we hope to have more throughout the year talking about gene therapy as well as other innovative products. I'll stop there and
Thank you, David. So as you're stopping sharing, I'm going to read out the first question. This actually came ahead of time. And it's a little bit of a broader speaking question, a little bit more global focused. How do we convince authorities in low and middle income countries to pay for gene therapy? Considering what we know in Canada.
Yeah, I mean, it's going to be difficult to convince them to pay for this in Canada. So you can imagine that's going to be much more difficult in countries where, you know, there's fewer resources. On the other hand, we've seen as each new generation of therapy has come online, we went from plasma-derived to recombinant to extended half-life recombinant to non-factor products like emicizumab, and now gene therapy. The previous generations of products became less expensive and more available to countries in the developing world. So my hope is, I'm not optimistic that gene therapy will be used widely in the short term around the world, but it could be helpful in expanding the range of products that are available, and maybe making some of them cheaper.
Okay. What happens if gene therapy is paid in some provinces but not others? Yeah,
I don't know the answer to that one. I think, we've made the case that there should be equity. It's not fair that, somebody in one province has access and somebody next door doesn't. And does that mean people will move? There's all kinds of problems related to that. So we'll certainly be doing our best to get access equitably across the country. And, we have people from our community listening today. It may be that we come back to you in a short time and saying, you need to start talking to your provincial governments. It's not going to be a one-size-fits-all like it was for past therapies that came online. This may be province by province, and we will need people to become active and strong advocates.
So on the flip side, would I or can I receive gene therapy if I live in a province where it's not administered but reimbursed? Do we know how?
Yes. Yeah, I mean, and Jerry might be the best person to answer this. It will be administered only in certain places in the country. It won't be administered everywhere. And so if it is reimbursed in your home province, then we'll have to make some provisions for people to be able to travel to the places where it is administered. And Jerry, you might want to jump in on that.
Yeah, that's a tough one, David. But the other part of that to keep in mind is something that I said earlier, that this is the first generation of gene therapy. there's lots of research in gene therapy. There are other clinical trials that are opening, that are being run. They will be run in various parts of the country. So another way another access point for gene therapy would be enrollment in clinical trials for people who are interested in doing that. There have been several centers that have enrolled patients in gene therapy trials here in Canada. And some of these will be other approaches to gene therapy. Some of the ones that I showed you using integrating gene therapy, even non-viral vector approaches to gene therapy. So there's clinical trials as well. I don't think we should consider that to be an end run around, because for one thing, we don't want to relieve the healthcare system of their responsibility of looking after patients, but that is another potential approach.
Thank you. In terms of advocacy, David, and access to treatments as they come online, and this could extend far beyond gene therapy to other novel therapies, what is the role of Canadian Hemophilia Society as a national patient advocacy organization in terms of advocating for access? And how do we do this as an organization?
Well, we've already started in that we make submissions to CADIF and to INES showing giving the patient perspective on the benefits of new treatments. So we've already educated the governments to a certain extent from our perspective. It'll be a bit different when we're talking about reimbursement, yes or no, and there it does become somewhat more of a political issue, and the people who speak up and make their voices heard have more chance than those who don't. And so we'll be coordinating that, as we did with previous campaigns to get access to therapies. Sometimes it takes a while. We had a great letter writing campaign 3 years ago with regard to emicizumab that really had an impact. But we also did lots of things behind the scenes. Talking to members talk to their provincial ministers of health. We talked to attachés politiques. We talk to government bureaucrats. We work with the doctors group. We're very close in having the same position, and so we work hand in hand. So all those things have to happen, and sometimes they involve actions by the membership at the grassroots level.
And what would happen if there's a situation where there has to be a cap in the number of patients that could receive this per year? Could you see this as a potential risk in terms of accessibility?
Well, I think there will be a capping. I mean, the companies will only be able to administer or deliver so many doses, and the centers will only be able to treat so many patients to start with. And so I think the question there needs to be, we need a system to identify those who need it most, who would most benefit from this. And I think that's already been discussed by the clinic directors group as something they need to think about.
And you raised a good point just previously in terms of our submissions to CADIF and INES, and maybe this is our request out to the audience, is that if you are a patient in the community and you're receiving these types of surveys, it's imperative that you help us fill these out, because this helps inform our arguments and our evidence to the actual authorities, whether it be the HTAs or government officials. So thank you, David, for bringing up that point.
And Sarah, there is a survey being underway right now for those with hemophilia A. Mm-hmm. So if you have hemophilia A, mild, moderate, or severe, or you're a caregiver, please find that survey on our website. It's open until June 1st.
Thank you. I'm going to end your last question, David, similar to the question that we posed to Jerry. What are you most optimistic about with the advancements that are being made with gene therapy, especially in the context of Canada in the current situation that we're in?
Well, I'm really impressed by the stability of the hemophilia B gene therapies. I think, patients told us that they want something that's going to last 10 years or more, and that's what it looks like. So that's what I'm most impressed by.
Thank you very much. And I'm going to now say thank you to all of our participants for joining us tonight. We've greatly appreciated your interest. We've had some overwhelming response, but please, if anyone you know is still interested in watching this, we are going to be having a recording up online in the next month. And I want to say also a big thank you to our sponsors of our gene therapy education program, Pfizer Canada and CSL Behring Canada. With their support, the CHS, all our healthcare professionals, and our team have been able to put together a wide-ranging resource network and set through the education program. But also, I want to say a big thank you to the participants for choosing to spend World Hemophilia Day with us. We are excited that we could come together in this forum. And we are looking forward to many other opportunities to be able to provide different types of education as we move through the cycle of gene therapy and other novel products. So please visit the Gene Therapy Education Program page on our website. We have a series of 10 podcasts, and we also will have soon to be 11, a debate on hemophilia B. And I'll address the important questions that have been coming to us from our community members. So on that note, I would say good night.
And you can stay on, right?
Yes, and if you're interested in staying on for our French webinar, which will be focusing a lot on the situation in Quebec, but also covering on very similar topics, please stay on this line. You can join us. And David will be speaking again. Have a wonderful night, everyone. Take care.
Thank you. Good night. Bonne nuit.
Night.